Takayasu arteritis presenting with an aortic arch thrombus, presented by myself, Ashwarya Verma, my co-authors Chirag Kar, Marley Thomas, and Pranay Korpo. Takayasu arteritis is a large vessel vasculitis predominantly diagnosed in patients under age of 40 and of East Asian descent. Symptoms vary depending upon location and extent of stenosis. We present a rare case of Takayasu arteritis diagnosed in a 44-year-old Caucasian female presenting with an aortic arch thrombus. A 44-year-old Caucasian female presented to us with a significant past medical history of alcohol use disorder, 30-pack per day smoking history, anxiety, and depression with a 4-month history of persistent and diffuse abdominal pain with nausea and vomiting. She also reported progressive worsening and cramping of her bilateral lower extremities, especially on ambulation. On examination, patient was noted to have diffuse right-sided abdominal tenderness to both superficial and deep palpation. Blood pressure was noted to be 166 over 125 in the right upper extremity, while no reading could be obtained in the left upper extremity. Pulses were noted to be 3 plus in the right upper and lower limbs, while only Dopplerable pulses could be seen in the left radial and dorsalis pedis arteries. Labs were significant for leukocytosis of 23.3, thrombocytosis 443,000, CRP 5.3, ESR 34, and creatinine 1.49. Given her findings, we did a CT scan of her abdomen and pelvis, which suggested sequel of embolic infarction, which can be seen in the scan presented in the slide. Multiple acute and subacute as well as chronic infarcts could be seen in the spleen as well as mid and lower right kidney. This prompted us to do a further CT angiogram of the chest and abdomen, which showed thrombus with filling defect in multiple regions, including distal aortic arch, left brachiocephalic artery, superior mesenteric artery, and right hepatic artery. Further imaging, including transesophageal echocardiogram, showed two large mobile masses in the aortic arch prolapsing into proximal descending aorta. A bilateral lower extremity arterial duplex showed evidence of severe digital ischemia in both lower extremities. So in summary, what we have here is a 44-year-old female with new onset Raynaud's of her left extremities, hypertension, abdominal pain, found to have multiple infarcts in the kidney and spleen, along with thrombus of the distal aorta and other major arteries. She was also noted to have elevated inflammatory markers and leukocytosis with no whatsoever evidence of hypercoagulability or infective process. In conjunction with rheumatology, she was diagnosed clinically with large vessel vasculitis, likely Takayasu arteritis. She was thereafter started on long-term steroids along with anticoagulation for 3 months and amlodipine for claudication-like symptoms and hypertension. A 4-month follow-up MR angiogram revealed significant improvement in the aortic arch thrombus compared to prior. Our patient is currently off Xarelto, although continues to remain on corticosteroids. She even reports subjective improvement in her claudication-like symptoms. In discussion, Takayasu disease is a chronic inflammatory disease of large and medium-sized arteries involving the aorta and its main branches. Estimated worldwide incidence is 2.6 cases per million, with women more commonly affected than men. The disease has mainly been studied in the Japanese population, but Western studies have also been published. The main finding is absent pulses or a pulse discrepancy of greater than 10 in the right and left extremities. The diagnosis of Takayasu arteritis is often delayed or even missed because of its non-specific presentation. Ishikawa's criteria and those of the American College of Rheumatology are some of the widely used tools available to diagnose this condition. The reason why our case report is so interesting is because although our patient does not satisfy the obligatory Ishikawa's criteria of age, she still behaves as a large vessel vasculitis. She was treated as such and even responded promptly to the treatment. There have been a few other cases like ours reported in other countries with atypical presentation of Takayasu, which prompts an urgent need for a new set of diagnostic criteria. These are the references used in our case presentation. Thank you very much.